I hope that after this 15 minutes of talk, you will be astonished to see that there is an elephant in the room. Every day we are practicing and we are missing something, right? And I'm the only odd man standing amongst other individuals because uh, this is not uncommon. I will prove with the statistical data. Even though it comes to the topic of uncommon conditions of diabetes, it is not actually uncommon. It is very common condition of diabetes, but uncommonly attended by all of us, right? So I hope that after today's talk onwards, we will be paying due attention to our patients for their mental health also, right? So we have to bridge the gap between the glycemia and well-being. So it runs hand by hand. Now let me prove what I've said, that is it common. Is it working now? Fine. So I hope I'm clear now. Fine, thank you. So every 1 in 10 adults now they live with diabetes. That's what IDF Atlas 2025 has said. But more than 600 million cases will be there by 2030, right? And that too also more in the lower socioeconomic countries. Depression has twice as the risk of normal individual as compared to the diabetics. And up to 40% of them, they face depression and anxiety. 40% is the prevalence. So if you are a diabetologist and if you are looking just 10 patients per day, then you are missing 4 patients with either diabetes-related mental conditions, be it depression or any other conditions also. So it is extremely common. Maybe macro and microvascular complications may be there, may not be there to initial phase of diabetes. But yes, diabetes and mental health conditions would be there from day one till you initiate insulin and patient goes to dialysis. So always keep in mind that there is a major complication and major elephant in the room which is ignored by all of us. And there is a dual burden because of this, because higher mortality and massive economic loss are there on the shoulder because you prescribe them fancy medications and every time patient comes up with the HbA1c 9 or 10, we'll study 2 cases also. And there is a call to action that no diabetes care is complete without mental health care. So we have to make sure that that part is properly entertained. It's a very wide topic and it's difficult to complete in 15 minutes if we go through detail. But just to have a classification of mental health disorders in diabetes, they are depression, diabetes distress, anxiety, generalized anxiety disorders, eating disorders, bulimia nervosa and everything, and cognitive impairment also. As today morning also we had a discussion on CGM workshop that one severe hypoglycemia will increase the chance of cognitive dysfunction by more than 20%, right? So that's the burden on patient, and then after 10 years, we'll be shouting at our patient that why did you forget this medication? Why did you forget the reports and why did you forget the glucometer readings? But you allowed the hypoglycemia and you did not recognize that patient might have cognitive dysfunction. And this prevails for type 1, type 2, GDM and rare cases of diabetes also. Hence, the umbrella is huge and it covers every aspects of diabetology. And does it gets endorsed by ADA and RSSDA? Yes, it does get, but we just don't recognize. I have deliberately kept 2024 slides that since 2024 only ADA has recommended that good quality of sleep is important for every diabetics. How many often and how frequently do we ask our patients that ratre barabar ho gaya tha ki nahi? We never ask that patient, right? And that's what they are saying, that duration 7 to 9 hours is the target, spending more than 85% of time in the bed while asleep. પથારીમાં સુઈ જવું અને આડા પડવું, that is the difference between these two. And target aim is that less than 90 minutes of social jet lag. So timing, duration and quality of sleep, all 3 matters. Even though this doesn't come under the domain of mental health, but without sleep you cannot have a good mental health, right? So you have to make sure that you ask a leading question to your patient, do you sleep properly, yes or no? That's very important. Now let's go to a very 2 case puzzles which we have. One is diabetes and mental health related case of Mrs. Sharma. These are the hypothetical case, but we often see them in our day-to-day cases. And the case puzzle 2 is for Mr. Shah, right? Now let's take it one by one. And throughout this talk, we will continue discussing this case, so it will be solved at the end. So Mrs. Sharma, she's 52-year-old female, type 2 diabetes, HbA1c is 9.2. Doctors have tried that base. I'm not going into the pharmacotherapy because we have a lot of plenary sessions on that. Symptoms are persistent sadness, low energy, loss of interest, poor adherence to medications and diet, and obviously uncontrolled diabetes. And clinician is confused that is these uncontrolled diabetes causing mood disorder or is it a clinical depression itself? But still he does not have a proper tool to answer and proper way to understand that I treat with the anti-diabetic medications or antidepressants or counseling or all together. On the other hand, case number 2, Mr. Shah, he's 28-year-old male, type 1 diabetes, and HbA1c is 10.1. Obviously, both are uncontrolled in diabetes. He has constant worry, frequent blood sugar checkups and frustrations. He has regime burnt out. And again, clinician has the same confusion. What should I do? What exactly should be the diagnosis? Is there any way by which I can put on paper that this patient is suffering from this condition and this is how I can improve that HbA1c? Because clinicians have tried everything for these patients, but HbA1c has not responded. So let's dive into two very, very important conditions. I cannot discuss everything in 15 minutes because it's a huge topic of psychology and psychiatry. But these two very common conditions I have picked up, as these cases are, we'll discuss at the end. That depression is extremely common, as what WHO 2023 says, that it is a common mental disorder which is characterized by... Is it working properly now? Okay. So depression is a common mental disorder which is characterized by persistent sadness and loss of interest in activities accompanied by inability to carry out daily activities for at least 2 weeks. Please remember this word, at least 2 weeks. And this definition has been incorporated for the tools also. Whereas diabetes distress, what ADA 2020 has defined is, it is a condition where there is an emotional burden of living with diabetes rather than the sadness of mood, right? It can recur. So the working definitions are very clear but difficult to understand. So what I have put is, on single slide I have put both of them. I have bifurcated these definitions so that as a clinician, when we have to judge the patient between depression and diabetes distress, we can easily recognize that this patient is in depression and this patient is in diabetes distress. So nature of depression is, it is psychiatric disorder. It is well defined, whereas diabetes distress is just an emotional reaction to a situation and not depression itself. Make it very clear, diabetes distress is not equal to diabetes depression. Nature followed by duration. Depression could be more than 2 weeks. It has to be by definition persistent symptom for more than 2 weeks. Whereas diabetes distress fluctuates. Say for example, you have a patient with type 1 diabetes, suddenly gets burnt of tears in front of you that I don't want to take insulin, my life is lost. How would I manage insulin? How would I manage for glucose? What about my marriage? What about my kids? And what about my family? And what about my future? So many thoughts they come together to them that I have 600 sugar, I'm in the ICU with decay, and what about my life? That is not depression, that is diabetes distress. A type 2 diabetic patient can also have that. When you start with the insulin, when you ask for the insulin, patient will think that you have asked for the kidneys. File ઉભા થઈને લઈને ભાગી જાવ સાહેબ ઇન્સ્યુલિન મારે નથી લેવું. That's a common reaction by everybody. As a human being, nobody wants insulin. There is a fear of insulin. That is not diabetes depression, that is diabetes distress. So as a clinician, we need to differentiate both of them. The impact of depression is a global functioning is impaired, whereas on the case of diabetes distress, self-care, adherence and regimes are affected. There are ways to answer this. If you want to properly evaluate, the internationally validated things are available. Unfortunately, we are not using it. What screening tool are available for depression? That is PHQ-2 and PHQ-9 score. And what screening tools available for diabetes distress are PAID-20 and DDS-17. So I will stick to these tools also because without diagnosis, we cannot treat. Do we have any blood investigations? Anybody? For diagnosing that you investigate in the lab and the depression positive negative comes or diabetes distress positive negative, it will never happen. It's a psychological condition. Hence, we should have a validated tool. So what clinical tools are there for diagnosis? Yes, so no single laboratory investigations. It's all about your understanding of tools. PHQ-2 screening is a screening tool where you just ask 2 simple questions and you can recognize that does patient requires detailed investigations for depression diagnosis or not. PHQ-9 is a detailed investigation which will tell you the severity of depression, right? And thirdly, I'm not ignoring PPD-20, but DDS-17 is endorsed by RSSDI, ADA all, and it is more useful for as a clinician. Hence, I will restrict myself to DDS-17 for diabetes distress evaluation. So, what about PHQ-2? It is all about initial screening. So, when you have a suspicion that something is wrong about patient psychology, patient doesn't look good, looks depression, and there is a question mark, as we had these for both patients, Mrs. Sharma and Mr. Shah, that you ask the patient these simple 2 questions, which I will explain you. And recognize whether the score is more than 3 or not. If score is more than 3, then you go for detailed investigation of PHQ-9. You cannot put a paper in front of every patient that fill up the form of PHQ-9, right? So patient would stand up and go away because a lot of things are happening in the OPD. Hence, the screening tool of PHQ-2 is very, very important. What is PHQ-2? It is Patient Health Questionnaire 2. Simple, the upper dark box, 2 questions that for past 2 weeks, remember always. Somebody has died in the family, you might be depressed for a week, but you cannot be depressed for more than 2 weeks. If more than 2 weeks have passed, and if you ask 2 simple questions, number 1, little interest or pleasure in doing things, yes or no, and they have to answer not only in yes or no, but response from 0, 1, 2, 3. 0 stands for not at all, 1 for several days, 2 for more than half of the day, and 3 is nearly every day. So 0, 1, 2, 3 for 1 question. Again, second question, feeling down, depressed, or hopelessness. Again, answer from 0 to 3. Now, if you have sum up, if patient answers maximum 3 plus 3 is equal to 6, and patients can answer 0, 0, that is 6, 0. So 0 to 6 could be the range of PHQ-9 scores answer. But if the score is 3 or more, that means there is a strong possibility that patient is going through depression. This is the candidate where you have to give him a form of PHQ-9 to stamp that there is a diagnostic requirement is available, and this patient should be offered PHQ-9, because 9 questions to every patient in the OPD is not practical. Hence, PHQ-9 is a simple screening tool. So most oftenly, 90% of cases, I would ask you to take these messages home. Ask these 2 simple questions to every of your patients, and third one, which I told you previously, that are you sleeping well or not? Very, very important questions in every diabetic patients. Now, something about PHQ-9, that is Patient Health Questionnaire 9. It is all about detailed, gold standard, endorsed by ADA, RSSDI, and American Psychiatric Association questionnaire. They are available freely online. You don't need to memorize them. You can take a printout and give it to your patient. This is how the 9 questions they look like little interest in pleasure doing for things, but everywhere there is a condition for depression. More than 2 weeks, symptoms have to be persistent, right? Somebody who is a cricket lover and India loses match against Pakistan, he would be not happy. That is not depression. So symptom has to be persistent for more than 2 weeks. That's why duration is very, very important. Question 2 is feeling down, depressed, or hopelessness, so on and so forth. I'm not going into the details because they are available easily as an online platform. And each of the PHQ-9 items are scored from 0 to 3. So total score could be 0 to up to 27. 9 questions, 3 mark each if somebody is signing. That is total of 27. So 0 to 27 is the range. And how would you rate the severity of to these patients? So like 0 to 4, patient has minimal depression, right? But mild is 5 to 9, moderate is up to 15, moderately severe from 15 to 20. And if score is above 20, then patient has severe depression. And usually severe depression, with a single point, if patient says that he has or she has a suicidal tendency with thoughts, that is severe depression irrespective of the score. So diabetes depression can be easily diagnosed with PHQ-2 followed by PHQ-9. Now what about you feel that patient does not have depression, but he just or she just have worries about the diabetes, how to manage, how to treat, what to do with the diabetes. Then it could be diabetes distress. But on clinical suspicions, it cannot be assured that distress is there or not. For that, to evaluate, we need to have a tool which is called as DDS-17 tool. So DDS-17 is a diabetes distress scale which includes 4 major pillars of diabetes distress: emotional, regime or treatment related, physicians related, or it could be interpersonal. So all 4 aspects has to be covered. And these all 4 aspects have been covered up in the diabetes distress 17 scale. How to administer, I'm not putting up the entire 17 questions, they are easily available, but I'm just putting an interpretation how practically you can do it. So there are 17 items which are rated from 0 to 6, right, from the scale. So 1 is not a problem for patient, 6 is a very serious problem for the patient. So 1 to 6 into 17. So highest score could be 102. If patient marks every question as 6, as the highest point from 0 to 6, for 17 questions, it will be 102, which is the highest score, and it could be even 1, which is the lowest score. So what you have to do is, you put the mark in front of the table that there are 17 questions and there are the answers from 0 to 6 from your side about your emotional well-being and understanding about this. Then you make a total, divide by 17, that will become this DDS-17 score. So for example, maximum possible score could be 102 by 17, right? That is 6, and minimum possible score could be 1, 17 divided by 17, because minimum is the 1 mark. So for 17 question, if somebody puts just 1, that means total is 17. If you divide it by 17, the score would be 1. The score could be range from 1 to 6. Now, how to interpret does patient has diabetes distress or not? If mean score is less than 2, there is little or no distress. Between 2 to 2.9, moderate distress. More than 3, high distress. And 3 or more indicates specific area needing target intervention. The benefit of DDS 17 is that those 17 questions are formulated based on those feelers. So treatment related, regime related, emotional or interpersonal, you can even calculate based on that sub-analysis also that this is the area where I have to intervene. For example, somebody is afraid of insulin. So he will mark everything low on every question, but in regime-related questions, he will mark on higher side. So you can even delineate he has fear of insulin. Or if you ask them SMBG for 6 times a day and they are worried, then they will mark on that part. So they might have investigation-related fears. So you can delineate even the corners where they are afraid of. So this is just a short summary of depression. PHQ2, PHQ9 is a tool, and for diabetes distress, DDS 17 and PAID 20. But PAID 20, because of lack of not going in detail, recommendation even by RSSDI is about DDS 17 score. Now you have come to a conclusion, what about treatment? So diabetes self-management, education and support is part of integral treatment. You have to educate, educate and educate. That's what is required for patients because you never know what kind of fear they have. Secondly, psychotherapy, pharmacotherapy and integrated care approach is required. Some of the antidepressants, it's not possible to discuss in detail, but like SSRIs are sertraline and escitalopram, they may go for GI upset and sexual dysfunction, but yes, they have good metabolic profile. SNRIs like duloxetine and venlafaxine, they do good on neuropathy, but they may increase blood pressure and nausea. Bupropion, please remember, XL is better drug because XL is 24-hour acting, and 1500 to 300 milligram is a daily dose. It is for insomnia patients, seizure risk, and even for erectile dysfunction patients. But you should be avoiding suicidal tendency and in the eating disorders. TCAs, amitriptyline, nortriptyline, to be avoided in weight gain and obesity patients and cardiovascular patients. But TCAs, nortriptyline particularly, is a good tool. Can I have 2 minutes more? So when should you decide which antidepressant suits to your diabetic patients in the given situation? So SSRIs and SNRIs, they are first line for moderate to severe depression in diabetic patients. They have well-established safety profiles. So sertraline, nortriptyline, sertraline and duloxetine, all those molecules are gold standards for management. Duloxetine has dual benefit of depression and neuropathy. Aripiprazole could be one of the good antipsychotic therapy required and has superior safety profile. But caution should be exercised when you use TCS for cardiovascular and obesity. Olanzapine or clonazepine are contraindicated in diabetics for uncontrolled diabetes, and bupropion should be avoided in suicidal tendency and food-restricted behaviors. There are certain antipsychotics and mood stabilizers also which have some metabolic consideration for diabetic people to choose. Higher risk patients like olanzapine have significant weight gain, but aripiprazole has low risk. So when given the choice, aripiprazole is better. Clozapine is having highest metabolic risk profile. So ziprasidone is a good drug as an alternative. Valproate associated with the substantial weight gain. So lamotrigine could be a good drug of choice. Whenever there is a questionnaire between you and psychiatrist, you can suggest that this is a better option. There are certain diabetes therapy which might have implications on psychological health, like insulin can trigger anxiety, SGLT2 can increase urinary frequency and sleep disturbance, give result sugar control, and they might be good for patients. And metformin, please remember, B12 deficiency is also important in cognitive decline because megaloblastic madness can occur. Now coming to these two cases, I hope that I have made the diagnosis clear. What Mrs. Sharma could have diagnosis: sadness of mood, more than 2 weeks. It's clear-cut depression, right? Mr. Shah worried about insulin regime, type 1 diabetes. He's not depressed, he's distressed. So I applied script for the patient, PHQ2, PHQ9 case, found out depression, and DDS 17 found out diabetes distress, both of them. Hence the diagnosis became very clear. The tailor-made medicine was given. Case 1, depression, antidepressants counseling were started, and case 2, there was no clear-cut depression, but education and understanding, empathetic explanation about how you can use your insulin in your routine, and it's very easy to go for in your routine life. Both of them showed improved outcome, and they were adherent and even improved. So this is the final outcome where we can solve the puzzle of diabetes, depression, and distress. That now Mrs. Sharma has been treated for depression. She has good control of HbA1c from 9.2 to 7.1, and she is happy and have significant improvement in food also. And Mr. Shah has been out of fear of insulins. He has been taking regular insulins, and now his HbA1c has dropped from 10.1 to 7.4. So without anti-diabetic medications also, you can create magic in your OPD, plus just make proper attention, because this is endorsed by ADA, RSS, and every guideline, but we have not been implementing in our routine practice. I think the takeaway message, please apply every possible tools. Ask 2-3 basic questions to your patients about sleep and about their mental health condition, and try to differentiate between depression and diabetes stress. It will be very, very much rewarding. Thank you so much.
Thank you, Dr.